Welcome back, everybody. David here again with Med School Bootcamp. Really quick video here, just something that's not commonly tested, but I want you to have been exposed to it before test day. It's a pathology that can theoretically come up, and that is autosomal dominant, so it's inherited, tubulointerstitial kidney disease. Sometimes this is also called medullary cystic kidney disease as well. So again, general overview, this is another type of cystic kidney disease. The location of these cysts changes, and that's what makes it unique. But this is inherited cystic kidney disease, similar to our autosomal dominant polycystic kidney disease and our autosomal recessive polycystic kidney disease. If we look at the pathophysiology here, the most common mutation is the autosomal dominant mutation in the UMOD gene, which encodes uromodulin. Uromodulin is a protein that's actually produced by the renal tubular cells in the loop of Henle, and thus is a protein that we can see in the urine as well. The overall function of this protein is not really well understood at this time. There are a couple other genes that can cause this condition as well, but the most common one is the one that we talked about here, and so that's the one I want you to be familiar with on test day. So what actually happens? Well, we're going to get tubulointerstitial fibrosis, as the name suggests, and this leads to renal atrophy, insufficiency, and ultimately renal loss. And so you can see how this is not all that different from a late stage autosomal dominant, right, or an autosomal recessive, where we get this kidney failure progressively. Patients are going to present with the progressive renal insufficiency and ultimately renal failure. You're going to see those labs that we expect to see in renal failure, such as increased creatinine, uremia, and volume overload. Okay, so the question is, how do we tell this apart in a test question? It comes down to the diagnostics. We're going to get a renal ultrasound again, same thing we've been talking about in the previous videos. But here's the thing, we're going to see small kidneys. We talked about in the last two, right? We get large cysts in large kidneys. The thing is here, in advanced kidney disease, we get small kidneys, and the reason is because of the location where the cysts develop. They develop in the medullary collecting ducts. Again, this gets back to its name of medullary cystic kidney disease, meaning the medullary portion of the collecting ducts. And because of this location difference, because of where they present, it actually causes the kidneys to shrink and they become smaller. These cysts are typically not visualized on an ultrasound, which is my next key point right here. May or may not be visualized, but if you see atrophy to the kidneys along with this progressive kidney disease, it's something to be mindful of. Particularly if the question tells you about a family history, right? Why is that so useful? Because this is an autosomal dominant condition. We expect to see it in multiple generations of a patient's family. And management of these patients is going to be very similar to what we've talked about previously. So if you haven't seen the two previous videos, go ahead and check those out. We went in detail on all of these things. ACE inhibitors, ARBs, only curative thing is going to be a transplant. And overall, these patients have a pretty poor prognosis. So when we think about a vignette here, they're going to give you a variety of different things, and they want you to have a differential for cystic kidney diseases. So we've talked about autosomal dominant polycystic kidney disease. We talked about autosomal recessive polycystic kidney disease. In the last video, we talked about multicystic dysplastic kidney disease, and now we're talking about autosomal dominant tubulointerstitial kidney disease. So I think the one that they're going to maybe try to confuse you with is autosomal dominant. They're going to give you an adult patient. So a 60-year-old patient is presenting. They have some abdominal pain. They've noticed some hematuria in their urine. You get some labs and their creatinine is significantly elevated, a sign of renal failure. And the key to answering the question and picking autosomal dominant tubulointerstitial over autosomal dominant polycystic is going to be the ultrasound findings, right? They're going to tell you that the kidneys are small, they're atrophied. That's not what you expect to see in autosomal dominant polycystic kidney disease. I expect large kidneys with big cysts. Here, we're not seeing that. So this makes me more likely to choose this condition, the tubulointerstitial kidney disease, because I know that is an inherited condition that can present similarly to autosomal dominant polycystic kidney disease, but the kidneys being small is really the main clue that they're going to give me here in the question. So a quick summary of this quick video, we have autosomal dominant, so it's inherited tubulointerstitial kidney disease, also called medullary cystic kidney disease, which typically has cysts develop in the collecting ducts. Reason this is important is because this can lead to tubulointerstitial fibrosis, renal atrophy, and progressive renal failure. We have small kidneys here rather than large kidneys, and this has to do with where the cysts are actually being formed. Management is going to be the same as the conditions we talked about previously, ACE inhibitors, ARBs, poor prognosis overall, but the only curative option is going to be the renal transplant.